parathyroid. It causes hypercalcemia, osteoporosis, and renal stones. The surgical cure is the definitive treatment, but it depends entirely on accurate preoperative localization. The current imaging modalities includes the technetium maybe SPECT-CT, which is the standard nuclear medicine tool with sensitivity of 70 to 80%. It misses 20 to 30% of the lesions and struggles with the small and ectopic adenomas. Also, false negatives occur oftenly due to rapid washout or small-sized lesions. Here comes choline PET to bridge the gap when maybe fails. It has high sensitivity of 85 to 90%, but it requires a cyclotron and faces cost-effectiveness issues in production with limited availability in many regions. So the need here is a tracer with choline-like sensitivity that is generator-produced and accessible without a cyclotron. And here comes the gallium trivehexin. What is trivehexin? It is a synthetic peptide engineered specifically to bind to alpha V beta 6 integrin receptors, which are significantly overexpressed in parathyroid adenomas compared to normal tissue. The benefit here that we have on-demand in-house production with simple kit-based labeling with gallium, similar to gallium PSMA. The biodistribution of gallium trivehexin, it has low soft tissue uptake, so we have clean background, renal excretion, and some uptake in gastric mucosa. The key advantage here is high tumor to background ratio, which results in superior lesion contrast. The international clinical evidence, Notny et al. In 2017 till 2020 conducted a preclinical and initial clinical evaluation confirming high affinity and specific binding of gallium trivehexin to alpha V beta 6 expressing tissues. This is a more recent study where they compared gallium trivehexin PET against technetium maybe SPECT-CT and fluorocholine PET-CT with two key findings. The first is that trivehexin identified 7 additional parathyroid lesions that were missed by technetium maybe scintigraphy. And the other key finding that trivehexin successfully identified hyper-functioning parathyroids in 2 out of 3 patients who were negative in fluorocholine PET. So trivehexin provides diagnostic accuracy. It offers superior sensitivity and lesion localization compared to technetium maybe, particularly for small or ectopic adenomas. It has high affinity for integrin expression, which enables more accurate preoperative planning. So it here bridges the gap when fluorocholine is not available, that it can be used effectively to detect parathyroid adenomas in situations where there is no access to fluorocholine. And here's a comparative analysis between the technetium maybe, the fluorocholine, and the gallium trivehexin. Both fluorocholine and gallium trivehexin has high sensitivity when compared to moderate sensitivity for maybe. Both gallium trivehexin also has high resolution. Generator production for technetium maybe and trivehexin, and the target differences. So let's now move to the most interesting part, which is some real case examples from our work at the Mesh Radiology Center. This is case number 1, a patient with elevated parathyroid hormone and increased calcium levels with repeated renal and gallbladder stones. Here we were able to successfully detect a superior mediastinal ectopic parathyroid gland. When the patient underwent surgical resection, it was proven to be parathyroid adenoma. Case number 2, with a patient with elevated parathormone, left inferior parathyroid solid mass on ultrasound, and inconclusive maybe scan. When we performed gallium trivexin, we found an active parathyroid nodule just posterior to the left thyroid loop. Case number 3. This is a patient with elevated parathormone and generalized body aches. Here is something extraordinary we found in the maybe scan, that we found right loop thyroid adenoma, and there were no any evidence for parathyroid adenoma, but everything changed when we performed the gallium trivexin, that we found a trivexin avid nodule posterior to the trachea and no trivexin avid lesions found in the thyroid gland. Here is another case highlighting detection of small parathyroid adenomas for a patient also with elevated parathormone and negative maybe scan. We were successfully able to detect a small parathyroid adenoma. Case number 5 for a 27-year-old female with history of hyperparathyroidism, underwent resection of 3 parathyroid glands, and there were pathologically proven to be parathyroid adenoma, but the patient is still presenting with elevated parathormone level. When we performed gallium trivexin, we found an ectopic parathyroid gland seen high in the neck, and that was the responsible for the elevated parathormone. The last case, a 26-year-old male patient with elevated level of parathormone and calcium levels with negative maybe scan. Here we were able to detect also another small lesion which was missed in the maybe scan. We will go through some other applications for the gallium trivexin. Alpha V beta 6 integrin is a broad target which is overexpressed in various epithelial cancers and fibrotic disease. Fibrotic disease like interstitial pulmonary fibrosis, and it have other oncological applications like pancreatic ductal adenocarcinoma, head and neck squamous cell carcinoma, triple negative breast cancer, and is being investigated for use in other carcinomas like lung adenocarcinoma, colorectal cancer, and cervical cancer. What are the advantages of gallium trivexin over FDG-PET in oncology? FDG-PET can be suboptimal due to low uptake or masking by inflammation, but gallium trivexin offers advantages in tumor with high alpha V beta 6 integrin expression, where traditional and metabolic imaging is limited. To conclude, gallium trivexin is highly effective for parathyroid adenoma detection and localization. It can be very helpful, especially in complex or inconclusive maybe scans. It could be a potential PET tracer alternative for regions that don't have access to fluorocholine. Thank you.
Thank you, Dr. Muhammad, for the very concise. We wanted the presentation to be short and to the point. Excellent work, Dr. Muhammad. Well done. So the conclusion of Trivexin is that in countries like in Egypt, where we don't have fluorocholine PET tracer, and we only rely on the technetium maybe, as you know, like Dr. Muhammad mentioned now, almost 30 to 40% of the maybe can be negative, and that's because of the ectopic or small lesions. In Egypt, these cases, we did not have any further investigations to detect where is the hidden parathyroid adenoma. And now, thanks to this new tracer, gallium trivexin, because we don't have access to fluorocholine in Egypt, so now we have another substitute that can be used as a PET tracer on a PET CT machine to have a good quality image with good CT localization to accurately detect where is the site of the parathyroid adenoma. And really, we've been using it for several months, and I think we really helped several patients detect the site of the nodule. Like Dr. Muhammad mentioned, we had many cases with negative MEBI, and then they do the trivexin, So now we see the lesion, and now we can help the surgeon to know where is the site of the lesion and to accurately resect it. So that's the main message that we wanted to highlight today. If you have any message you want to, any question or any message you want to mention, please write it down in the Q&A or in the message box. We hope everything was clear, but if you have any questions, we would love to have a discussion. Okay, let me ask you, what about FDA approval? It is not, Dr. Muhammad, do you want to go for this?
No, you
We
can
have a
proceed,
question.
Dr. Yahya. Yeah, no, you can proceed.
So we have a question from Isra Gamal. What about FDA approval for Gallium-Trivexin? It is not yet approved for this indication. So far, it is not yet approved for parathyroid. However, the early results from around the world show that it shows high sensitivity to detect it. Some studies showed up to 95% detection sensitivity. So far, still not approved, but initial international worldwide results seem promising. Another question, Dr. Muhammad, did you experience uptake in thyroid nodules? Dr. Muhammad, do you want to go for this question?
Yeah. We experienced in few cases, but it was very low grade uptake. And I remember one of these cases was pathologically proven later to be a papillary thyroid cancer. That's right, Dr. Yahya? Yeah, but it has a very, very low insignificant uptake. We didn't see true avid lesions in the thyroid.
So for benign nodules, we did not see any uptake. We only saw uptake with a malignant nodule, and it was very low uptake. That to conclude this question. Dr. Muhammad, do you think so far in Egypt we should be doing Trivexin for negative MEB cases, or do you think we should start straight away with the Trivexin?
It's a tough question, hard question to answer, and no straightforward answer for this question. I suppose that we can start selecting our patients. I started to link between low parathormone level, it's still abnormal, but still not too high, and negative maybe scan. So in such patients, we can start directly with gallium trivexin. In patients with higher levels of parathormone, we can start with maybe and give them a chance for a cheaper and more accessible scan. This is just an opinion for now. We cannot build on it.
Sarah Galal is asking almost the same question as a clinical scenario. So the patient comes with elevated parathormone and then elevated calcium level. So we're suspecting primary hyperparathyroidism. So we do the Trivexin straight away or not? So Dr. Muhammad mentioned now he prefers so far. Of course, this is initial experience. Of course, all what we're saying might change with further data in the future. But for now, probably if the parathormone level is very high, with the negative, we start with the MEB. If it does not get it, then we can go for the Trivexin. If the parathormone level is abnormal but still not shootingly high, then maybe this lesion would be small. So maybe we can try with the Trivexin straight away. Again, this is assumptions. This is not proven. This is not clinically approved. However, that's still our initial experience, which will probably change in the future. Dr. Awad, how are you, Dr. Awad? We hope to see you soon in Egypt. He's asking, what's about parathyroid hyperplasia?
It can be diagnosed in both maybe and Trivexin. The important point that in hyperplasia, it affects the 4 glands, and we will see lower grade uptake in the 4 glands, not shooting SUV max for the lesions. This is a difference between the parathyroid adenoma and parathyroid hyperplasia. But at the end, it can be detected. Yeah, if you are asking detected or not, yes, it can be detected with gallium trivexin, with the way I explained before.
Another question, Dr. Mohammed. You also mentioned other applications for the trivexin. Other than the parathyroid, you mentioned that there are other non-oncologic applications and oncologic applications.
Yes.
Which of them is the most interesting that you want to maybe try, or you think that has future application? Which one of them is the most interesting to you?
The pancreatic ductal adenocarcinoma, the head and neck squamous cell carcinoma, and the triple negative breast cancer. And this also will open a door for theranostics, because there is work in progress on lutetium trivexin for treating of pancreatic cancer. And this will open the door beyond SSTR and PSMA theranostics for other tumors like pancreatic cancer, triple negative breast cancer, and head and neck squamous cell carcinomas.
So like to wrap up what Dr. Mohammed mentioned, that trivexin, it is now diagnostic, but in the future, it will be labeled with lutetium or with any other therapeutic isotope. And as any theranostic pair, it will be able to diagnose certain disease as well as to treat them when it is labeled with the therapeutic isotope.
Yes,
I think we can. Go ahead.
There's work under progress for treatment of a patient with pancreatic carcinoma with lutetium trivexin, and we are waiting for the results.
Very good. Okay, I think our point was clear. We wanted again the talk to be short, precise, to make it more for everybody to be focused and to focus on our main interest for today, which is using trivexin in parathyroid adenomas. I hope this brief, concise talk was useful to you. And there is another question, Dr. Mohammed, before we close. What about secondary hyperparathyroidism? Do you have any comments?
Only we have done like 2 cases, I think, for secondary hyperparathyroidism. We also were able to detect the brown tumors, and they were active. One of these cases was diffuse lesions across the skeleton. That's the only finding we can see.
Yes, we saw the bony brown fat. Of course, there was no primary hyperparathyroid nodules. It was probably a renal cause. So we saw multiple bony lesion. It was a very interesting case. Maybe next time, Dr. Hamad, you should show it in your next presentation.
Okay, I will.
Okay, thank you for your time. It was very nice having you all. And thank you again for your time. And I hope we can arrange further meetings in the future. Thank you very much for your time. Thank you, Dr. Mohammed.
Okay, thank you.